Dr. Ashraf.
Thank you very much for this nice introduction. It's really my pleasure and honor to be with you today for this outstanding international conference. And I would like to deeply thank Professor Dr. Amal Bashlawi for always inviting me annually for this kind of outstanding conference. Thank you. It's really an important topic. We all know that hepatitis C virus is a national problem in our country. Egypt is having the highest prevalence worldwide. It was 14%, and recently it has been now reduced to just 7%, according to the excellent program in fighting this kind of a major problem in our country. Hemoglobinopathies is like sickle cell disease is the most common genetic defect that results in an abnormal structure of globin chain that leads to hemolytic anemia, thalassemia, alpha or beta, a group of autosomal recessive hemolytic anemia due to a decrease or absence of synthesis of a globin chain. Patients with hemoglobinopathies were at high risk of acquiring hepatitis C virus, of course, due to the multiple transfusions, especially in patients transfused before 1992, when screening blood donors was still not available. Infection has been reported to about from, according to the area, from 4% to up to 85%. I think in our country, it may be more than 2/3 of patients having hemoglobinopathies is already infected with hepatitis C virus. So the mechanism of the liver disease in patients with hemoglobinopathies, of course, as you know, that the multiple transfusion with this erythropoiesis plus the presence of hepatitis C and or B and the iron overload, of course, accelerating the liver injury, accelerating the process of fibrosis, the liver cirrhosis, and extremely increases the risk of hepatocellular carcinoma. Also, patients may have also another comorbid factors like NAFLD, non-alcoholic steatohepatitis, or alcoholic liver disease. When you see the cause of death in thalassemia, of course, after heart disease due to iron overload, it becomes liver cancer. And in the recent years, the liver disease became much more important as a cause of death in cases of thalassemia, maybe after the presence of chelation agents. The presence of liver disease is being a major risk factor for death in patients with thalassemia. Of course, the presence of hepatitis C virus with the iron overload, as you can see, increases, accelerating the fibrosis progression significantly as compared to patients without hepatitis C or with mild iron overload. But in patients with hemoglobinopathies, the standard of care treatment in the past was pegylated interferon, as you know, with or without ribavirin. And recently, the new introduction of the directly acting antivirus, the protease inhibitors, NS5 inhibitor, NS5B or A, all these changing the whole story with a great success rate. Here is the options of the treatment. The standard of care in the past, which was based on interferon therapy with without ribavirin, and recently the introduction of the new DAs, the NS5A or B, NS4A, and NS3. What about the standard of care? The standard of care of the interferon alpha and either monotherapy or with ribavirin, the success rate, as you know, ranged from just 40 to 60%, with a lot of side effects, of course, as you know. Ribavirin with genotype 1 infection significantly benefit from the addition of the ribavirin patients, increases the success rate. However, the presence of ribavirin is associated with 30 to 40% increase in the transfusion rate. Here is the SVR, the success rate. in interferon-based therapy, just 40 to 60% only. A lot of relapses, a lot of non-responders. Then, when we study shortly the genomic organization of the virus, you know that it consists of two main structures, the structural proteins and the non-structural protein. Anyway, and the basic treatment based on the non-structural protein, which is the NS3, NS4, NS5A and B. Here is three main families, three main groups of treatment for hepatitis C based on the non-structural protein parts, the NS5B, the sofosbuvir or dazavir, the NS5A inhibitors, Dacla with lidisprevir. Then the NS3 and NS4 protease inhibitors, the simiprevir. Most of these all drugs are present in our country and changed the whole story with a great success rate among our patients. According to the recommendations to the European Association for the Study of Liver Disease, the incidence, the indication of Hep C virus therapy are the same in patients with and without hemoglobinopathies. It is the same. Patients with hemoglobinopathies should be treated with interferon-free regimen without ribavirin. The anti-hepatitis C regimen that can be used in patients with hemoglobinopathies are the same as in patients without. When the use of ribavirin is needed, careful monitoring is recommended and blood transfusion may be required. These were the recommendations according to the European Society of Liver, Association of Liver Disease. And now the option now is interferon-free regimen. We canceled now the interferon-based therapy, and we are now, the treatment now based on the new regimen of the directly acting antivirus. So the available regimen was sofriba or sofsem, sofdacla, sofledisbevir, اللي هو الهرفوني أو الكوريفيو. All these drugs are available in a very suitable price to all kinds of patients. Here is one of the recent studies based on the interferon-free therapy, and most of the cases there was no need for increased the transfusion with a great success. Only patients receiving ribavirin may need increase the transfusion rate. One of the recent studies with Sofledi, which is called the Harvoni in patients with sickle cell disease, the success rate was 92%. And here is another study, recent study, interferon-free regimen. Here is the level of the ferritin, 545, and most of the cases are different genotypes, genotype 1, 2, and 4. And the treatment, some are already had treatment before with failure. And again, the success rate was about 90%. Here is the regimen was sofosbuvir, simispivir, sofdacla or sofdacla with ribavirin for just 12 weeks. It is the same regimen as patients without hemoglobinopathies. Another more recent studies with different combination, interferon-free regimen, sofsem, dacla or curevo, all for just 12 weeks. Only the transfusion rate increased just in 3 patients out of 10 due to the addition of ribavirin. Side effects, adverse effects were very minimal, almost negligible. The interferon regimen-free also is having a very high SVR, 12 success rate at 12 weeks, mostly got cured. Another new regimen, thalassemia patients, sickle cell anemia versus thalassemia versus hemophilia, von Willebrand disease, 160 patients randomized to immediate treatment with the new regimen or deferred treatment where patients received placebo for 12 weeks. And as you know, all the patients, all in all patients have had a success rate more than 93%. For the subgrouping, for patients with sickle cell anemia or beta thalassemia, the success rate was more up to 95, 97%. Another more recent study, same Ladisbevir or the Harvoni with 100% success rate. Very mild side effects. Cirrhosis was associated in 15%. Treatment chronic C with direct-acting antivirus, treatment with beta thalassemia major and advanced liver disease. A more recent study in this year, 2017, 61 with beta thalassemia major. Treatment experienced already had treatment before in about 75%. Cirrhotics was on about 80%, 50% genotype 1, and here is the success rate, almost 100% in all, specifically in genotype 4. The all results about 90%, no unexpected adverse effects, no clinically meaningful drug-drug interaction, and patients who received ribavirin had increased need to blood transfusion. So, in conclusion, patients with chronic hepatitis C and hemoglobinopathies can be successfully treated with the directly acting antivirus. Treatment is well tolerated with no drug-drug interaction with the chelation agents. Treatment was excellent and safe, even in difficult to treat patients, suggesting that this kind of group of patients should no longer be regarded as difficult to treat. Hematological side effects from ribavirin use can be easily managed by just increasing the rate of transfusion, and the SVR should lead to significant decrease the liver failure cases and thus prolong the life expectancy in these kind of patients. And finally, as been mentioned before, that these kind of people should be managed in a multidisciplinary way. Thank you very much.
Professor Ashraf, thank you.